Today we will discuss Chapter 18, Comfort, Rest, and Sleep. The objectives of this lesson. After reviewing this lesson, you'll be able to differentiate between comfort, rest, and sleep. Describe 4 ways to modify the client environment to promote comfort, rest, and sleep. List 4 standard furnishings in each client room. State at least 5 functions of sleep. Describe the general trend in sleep requirements as person ages, and name 10 factors that affect sleep. Name 4 categories of drugs that affect sleep. Describe 4 techniques for assessing sleep patterns. Describe 4 categories of sleep disorders. Discuss at least 5 techniques for promoting sleep. Name 2 nursing measures that promote relaxation, and discuss unique characteristics of sleep among older adults. Comfort facilitates rest and sleep. One factor that contributes to comfort is a safe, clean, and attractive environment. This chapter addresses measures for ensuring that the setting for client care promotes a sense of well-being. It includes measures for maintaining the order and cleanliness of the client's bed and room, and describe nursing interventions that facilitate rest and sleep. If you think about when you go into a room at the hospital, you'll notice that many of the rooms they attempt to hide a lot of like the suction oxygen material. And if you think about the Alzheimer facility, they make them look like bedrooms, or they even make them look like things from the eras when they were younger, and that this will help ease the client's fears and anxieties and make them think that they are at their home. And this is to help make them feel safe and calm and comfortable. Is the following statement true or false? Client rooms resemble bedrooms that are bare, white, and have sterile environments. The answer is false. Client rooms are now bright, colorful, and tastefully decorated. This helps the patient feel welcome, feel calm, and eases anxieties. The term environment, as used here, refers to the room where the client receives nursing care and its furnishing. In the broad sense, however, the healthcare facility's location and design involve many other subtle elements that influence the consumer's overall impression of the institution. Most clients are unaware of the thought and consideration that goes into their surroundings. There's many people that are involved with decisions that go into what the hospital will look like. For example, there's discussions about parking, lighting inside and out, the physical plants, the landscaping, the barriers that reduce the traffic and noise. And so when they start looking at what the actual rooms will look like the walls, there's actually a lot of thought as to even like color schemes and wallpapers. You know, they'll look at things like colors. They'll blues and colors with blue tints like mauves, they promote relaxation. So these color schemes are preferred within the healthcare settings and in client rooms. They may actually like integrate wallpaper and trim and decorative accessories to kind of with images that like peaceful images to make patients feel relaxed. Because flooring is important because there's a lot of foot traffic, and so there was a push, a public service kind of push in the hospitals for a time where it was like quiet hospitals help healing. So there's a lot of thought as to like what flooring they even use in the hospitals because noise interferes with comfort, and hallways and workstations. In some places they like to use carpeting. I know they went away from that kind of a while ago, but they'll pay attention to what type of linoleum or they'll use, because if it's a loud flooring, they're unlikely to use that. And then they need to also be able to clean, right? So that's why they really pay attention as what type of flooring they put in. And then lighting, they need to be able to have adequate lighting and make it adjustable also. So they need to have both natural and artificial light. It's important for comfort of clients and nursing personnel. So now you're starting to see the newer buildings, they'll have larger window areas, atrium skylights, and also bright artificial light facilitates nursing care, but it's not actually conducive to patient comfort. So you'll see like most client rooms have multiple lights in various locations with adjustable intensity. because patients also need to be able to sleep, right? Just because we're a 24-hour facility, we also need to encourage sleep, because that's how they're also going to be able to heal. We also, if you've ever gone to a meeting or you go to into your class and it's like really cold, people complain a lot. So we also need, there's also a lot of effort into climate control. So climate control refers, to the mechanism for maintaining the temperature, humidity, and ventilation. And so there's also quite a bit that goes into that, because if improper temperature or humidity, there's the potential for bacterial growth and things like that. But we also want patients to be comfortable. So newer buildings are providing temperatures in each room so that the temperature can be adjusted to suit the client. We also want to have the relative humidity be able to control, and if the environmental temperature becomes greater than the skin temperature. And so there's a lot of things that go in, and so we want to make sure that we're able to provide effective, thermoregulation and things like that. So there's more than just picking nice wallpaper or nice pictures. They do it for patient. If they like it, they're doing it for the patient, but they're also doing it to help the facility as well run smoothly. But there's a lot more effort that goes into it than just picking nice decor. So as we continue talking about the patient environment, let's talk a little bit about the room furnishings. So manufacturers of hospital furnishings attempt to design equipment that is both attractive and practical, right? They want it to look nice, but it also needs to be practical for the staff. So the bed and its components, the mattress, pillows, chairs, over bed table, and bedside stand, all must be safe, durable, and comfortable. So the hospital beds are adjustable. That is, we can raise the height, we can reposition the bed. Some beds are even really cool that they even go to chair position. So if patients aren't able to get out of bed, we can get them up in the chair position. Hospital beds, of course, we need to always make sure that they're in their lowest position, locked, when it's just the patient. But when you're saving your back, because you plan to be at this job for a long period of time, you always want to make sure that you're trying to save your back. So you want to make sure that you're working by raising the bed to the highest position. Then, of course, they usually have full or half side rails that are attached to the bed frames. And of course, if you're raising all four side rails, there is some controversy, but that is actually considered a restraint. And side rails cannot be used as a form of physical restraint in long-term care facilities, and for their use of safety, they need to be justified. Some beds have removable headboards, and this actually facilitates resuscitation efforts if the client experiences respiratory or cardiac arrest, and you can actually remove the headboard and place it under the patient on some beds. And then mattresses, they need to be good enough to provide comfort, right? Nobody wants to come to the hospital and not feel good and then have a terrible mattress. But also we want to make sure that the mattress isn't too soft, which alters the alignment of the spine, but we also don't want it to be, terribly hard either. Occasionally we can actually put mattress overlays, and they are used to promote comfort or keep the skin intact. But again, they can be therapeutic mattress of foam, gel, air, water, if they're appropriate for the patient. Pillows are primarily used for comfort, but they can also be used to elevate a part of the body, relieving swelling, promoting breathing. We also use them a lot when we're turning a patient every 2 hours. They really help us be able to turn a patient and help, maintain that position. Bed linen, we have the mattress pad, but there's a bottom sheet. Sometimes it's fitted, sometimes it's not, depending on what kind of facility you work in. You can have the optional draw sheet that is placed beneath the client's hips. Those are really good because you kind of put the flat sheet or the fitted sheet, and then you put a draw sheet, and then you can put the chucks underneath. And then when you're moving the patient, because the chucks are the pad, when you use the draw sheet, you can lift by the draw sheet to kind of move the patient up and down in bed. And then the blanket or sheet, depending on the patient's preference or depending on what kind of linen you have. And the privacy curtain is always should be used, and that's it's a long fabric partition mounted from the ceiling, and it can be drawn completely around the bed, and this helps preserve the client's dignity and modesty whenever it's necessary to examine or expose him or her, because you want to make sure that you are maintaining their privacy all the time. And so even if they're in a single room, you want to use the privacy curtain, because if somebody knocks and just walk right in, if you have the curtain closed, if they're using the urinal or the bedpan, something like that, or you're changing or dressing, you have the privacy curtain closed. If someone just walks right in, at least the door, at least the privacy curtain's closed, so that way you're maintaining their privacy at all times. So to finish up the client environment room furnishings, so the over bed table is a portable table with a flat platform positioned over the client's lap. So these are nice because you can kind of adjust them. You can have them at the side of the bed. You can kind of place them over the patient while they're in bed, and you can like place the tray. You can place the tray. They can use these like to brush their teeth, whatever they want to use them for. Nurses also use the overbed table to hold equipment when providing care, and some overbed tables actually have a little compartment that maybe contain a mirror or something like that. The bedside stand is kind of like a nightstand. It's a small little cupboard. It usually contains drawer for personal items or 2 shelves. And here is where you can store the client's bath basin, soap dish, soap, the little emesis basin. The elimination utensils are kept separate from the hygiene supplies. Of course, you want to reduce the transmission of bacteria and microorganisms. There's also chairs at the bedside, and generally there's at least 1 chair in the hospital in each room, but sometimes you can get more chairs available, and these are usually straight back chairs to facilitate good posture and support. They may or may not be upholstered, or you may be able to find a recliner, but although upholstered chairs are more comfortable, some clients find it difficult to rise from, so that's why we kind of want just that regular straight back chair. We need to be careful, like in special care areas such as orthopedic units, modified chair called hip chairs may be used also. And hip chairs have a higher than usual seat that makes sitting and standing less difficult. So now let's move away from the hospital environment, and let's talk about sleep and rest and the functions of sleep. In addition to promoting emotional well-being, sleep enhances various physiologic processes. Although the exact mechanisms are not totally understood, the restorative functions of sleep can be inferred from the effects of sleep deprivation. Sleep is believed to play a role in the following: promoting emotional well-being, reducing fatigue, stabilizing the mood, improving blood flow to the brain, and increasing protein synthesis. Sleep also helps with maintaining disease-fighting mechanisms of the immune system, promoting cellular growth and repair, and improving the capacity for learning and memory storage. Sleep is split into 2 major divisions: non-rapid eye movement, or NREM sleep, and rapid eye movement, REM sleep. These names derive from the periods during sleep when eye movements are either subdued or energetic. Non-rapid eye movement sleep is quiet sleep. It is called slow wave sleep because during this stage, waves appear as progressively slower oscillations. NREM1 sleep, which occurs at the onset of sleep and lasts about 10 minutes, is characterized as drowsiness and light sleep. Sudden twitches called hypnagogic jerks are common. During this early stage of sleep, a person may be aware of sounds and conversations, but avoids arousal. During NREM2 sleep, the response to outside stimuli is somewhat suppressed. It is believed that memory and information begin to be processed at this time. The deepest and most restorative sleep occurs during NREM3 sleep, during which it is difficult to awaken a person. Dream may occur during NREM3 sleep, but it is not as vivid or as memorable as that which occurs during REM sleep. During the latter two stages of NREM sleep, blood pressure decreases and breathing slows. Hormones for growth and development are secreted in young persons. The REM stage of sleep follows NREM stages. It begins about 90 minutes after the onset of sleep and therefore cyclically recurs and lengthens as the hours of sleep progresses. REM sleep is referred as a paradoxal sleep because the electroencephalographic waves appear similar to those produced during periods of wakefulness, indicating that the brain is quite active in concentration and thinking. However, the body is relaxed, immobile, often completely paralyzed, and unresponsive during REM sleep. It is during REM sleep that dreams take an intense and dramatic quality that can be more easily recalled than those that occur in NREM3 sleep. When REM sleep is interrupted, the person tends to compensate by deviating from the usual progression of NREM to REM, returns to REM earlier than usual, and stays in REM sleep longer, a phenomenon known as REM rebound sleep. If REM sleep is chronically shortened, the ability to learn complex tasks is impaired. So let's discuss sleep cycles. During sleep, people alternate between NREM and REM phases. NREM sleep normally precedes REM sleep, the phase during which most dreaming occurs. Although the time spent in any one phase or stage varies according to age and other variables, most people cycle between stages 2 and 3 of NREM to REM phases 4 to 6 times during the night. The average length of NREM to REM sleep cycle is between 90 to 120 minutes. So sleep requirements. Sleep requirements vary among different age groups. The need for sleep decreases from birth to adulthood, although individuals vary. Although an average of 7 to 9 hours of sleep is a requirement for young adults, through older adults, many Americans report sleeping less than 6 hours a night. So how many hours is an age group required to sleep? So newborns from 0 to 3 months need about 14 to 17 hours of sleep. Toddlers ages 1 to 2 years need about 11 to 14 hours of sleep. School-age children ages 6 to 13 are recommended to get about 9 to 11 hours of sleep. Teenagers 14 to 17 years of age need about 8 to 10. Young adults ages 18 to 25 need about 7 to 9 hours of sleep. Adults ages 26 to 64 need about 7 to 9 hours of sleep. And adults aged greater than 65 years are recommended to get 7 to 8 hours of sleep. Are you getting enough hours of sleep? So let's talk about factors that affect sleep. Both quantity and quality of sleep decreases with age. Older adults suffer disproportionately from chronic sleep deprivation. This is not surprising because older adults awaken more frequently during the night. This is from several reasons, right? They may have pain from medical conditions. They may have smaller bladder capacity, which can be, they may have to get up more times a night to go to the bathroom. They may even have dementia-related sleep problems. They could have side effects from medications like diuretics and diminished production of neurochemicals such as melatonin that promote sleep. There's also other factors that are not related to the age that may affect the amount or quality of a person's sleep. And so there's things like light actually affects. Daylight and darkness influence the sleep-awake cycle of the circadian rhythm. And so researchers suggest that the cycles of wakefulness followed by sleep are linked to photosensitivity system involving the eyes and the pineal gland in the brain. And so if there's too much light in the room, or their body doesn't, maybe they don't go outside enough, they don't actually sense the light and dark, and so they have trouble sleeping. Then they may have activity, especially exercise, increases fatigue and the need for sleep. And so activity appears to increase both our REM and NREM sleep, especially the deep sleep of NREM. And so when physical activity occurs just before bedtime, however, it has a stimulating rather than the relaxing effect. Also, the environment. Most people sleep best in their usual environment. They develop a preference for a particular pillow, mattress, blanket. They also tend to adapt to unique sounds of where they live, such as traffic, trains, hum of appliances. And so people tend to get in what is called like sleep rituals. And so sometimes if they have changes in their environment, they're unable to sleep well. Like if they go to the hospital, they go to vacation, they may have trouble falling and remaining asleep. Also motivation, when a person has no particular reason to stay awake or sleep. Sleep generally occurs easily, but if the desire to remain awake is strong, just like when a person wishes to participate in something interesting or important, the desire to sleep can be overcome. Let's continue discussing factors affecting sleep. Emotions and moods can affect sleep. Depressive disorders are classically associated with an inability to sleep or the tendency to sleep more than usual. Also, emotions such as anger, fear, anxiety, and dread interfere with sleep. All are more than likely the results of changes in the types and amounts of neurotransmitters that affect the sleep-wake center in the brain. Food and beverages also affect sleep. Hunger or thirst interferes with sleep. The consumption of particular foods and beverages also may promote or inhibit the ability to sleep. Alcohol is a depressive drug that promotes sleep, but it tends to reduce normal REM and deep sleep stages of NREM sleep, as alcohol is metabolized, stimulating chemicals that were blocked by the sedative effects of the alcohol surge forth from neurons, causing early awakening. Beverages containing caffeine, a central nervous system stimulant, causes wakefulness. Caffeine is present in coffee, tea, chocolate, and most cola drinks. Illness also affects sleep. Stress, anxiety, and discomfort accompany almost any illness, which can alter normal sleep patterns. In the hospital, other factors that contribute to sleep loss or fragmentation include being aroused from noise from equipment, awakened from nursing activities, and disturbed by unfamiliar sounds such as loud talking, elevators, carts, housekeeping equipment. Drugs also affect sleep. Caffeine, nicotine, and alcohol, which have already been discussed, are non-prescription drugs that affect sleep. Some prescribed drugs can also interfere with sleep. Sedatives and anti-anxiety drugs promote rest, are also a precursor to sleep. Hypnotic are drugs that induce sleep. Stimulants cause wakefulness. Question number 2. Is the following statement true or false? Alcohol is a depressive drug that promotes healthy sleep. The answer is false. Alcohol is a depressive drug that promotes sleep, but it tends to reduce normal REM and deep sleep stages of NREM sleep. So when patients now come in and they're complaining of, fatigue after getting sleep, if they're coming in complaints of, headaches upon waking. The next thing the nurse needs to do is complete a detailed sleep assessment. And so we're going to talk about now is the sleep questionnaire and the sleep diary. There's been several questionnaires that have been developed to identify sleep patterns. They're either designed to obtain specific information or are unstructured to give the person more freedom to respond. Nurses can gather data during interviews, or clients can answer the questions independently in the form of a self-reporting assessment. So what you're going to do is you're going to be asking the patient questions about, like, when do you when you think about your sleep, what kinds of impressions do you have? Or you'll ask questions like, does anything about your sleep bother you? Do you fall asleep at inappropriate times? Do you wake up feeling rested? And that's one of the big questions that you'll want to focus on, is how they feel when they wake up. Because if somebody is sleeping all night and they wake up and they don't feel rested, or they have headaches, or their mouth is dry, or their mouth is dry, does that mean that their mouth's been open all night and they've been snoring loudly? How long does it take you to fall asleep? Do you feel stiff or sore all night? Have you been told that you stop breathing while you sleep? These are all important questions. Do you fall asleep during physical activities? Maybe even questions like, when you drive in the car, do you need to fall asleep? After eating a meal without alcohol, do you fall asleep? I mean, most adults should be able to go function during the day without the need for a nap, right? So what do you do to help yourself sleep well? So examples, so these kind of questions should also be for family members as well, because there's been times that, you talk to people and they're like, I don't snore, and you talk to the spouse and the spouse is like, oh yeah, he or she totally snores. So, like, does the client snore or gasp for air when sleeping? Does the client kick or thrash around while sleeping? Does the client sleepwalk? All of these are really important questions to ask, and also ask the family members as well. So the sleep diary is a diary of daily accounts of sleeping and waking activities. The client compiles this information for the sleep disorder clinic. So they note times he or she sleeps, what time they go to bed, what time they wake up. They describe daily activities during each 15-minute waking period. They complete a 24-hour log of consumed food and beverage, and notes when he or she takes any medication. The only problem is that, while they're easy and cheap, the problem is that they can vary in accuracy or liability. So sleep assessments include other objective diagnostic techniques for gathering data to ensure accurate identification of sleep disorders. So those are like some assessment tools, but now is when you actually order like sleep studies. And so the nocturnal polysomnography is what you would consider like a sleep study. And so is a diagnostic assessment technique in which a client is monitored for an entire night's sleep to attain physiological data. It generally takes place in a sleep disorder clinic, but now some people can actually do them at home as long as they live fairly close to the facility. And so what they do is they put like electrodes like on the head. They put like cardiac leads on. Um, they put like a strap across the tummy and like across, or the stomach, excuse me, and across the chest. And they'll put electrodes on the legs. And they're looking for they'll monitor brain waves, they'll monitor eye movements, they'll monitor limb movements, they'll monitor the body movement, they'll monitor nasal and oral airflow, chest and abdominal respiratory effort, snoring sounds, oxygen levels. So basically you stay there for 8 hours. They're also recording video recording of your sleep. And what they'll do is they'll also like the pulse ox monitoring, and they'll watch you sleep and they'll take recordings. And sometimes, if you're having snoring and obstructive airway and your oxygen saturation is dropping, they'll come in about 3 or 4 hours into your sleep and they'll put you on CPAP. And then they'll titrate it and hopefully be able to bring up your oxygen level and almost basically like treat the sleep apnea and then see how you do. And then when you return back to the doctors, they'll order like CPAP for that sleep apnea. So this diagnostic data are compared with the patterns and characteristics of normal sleep cycles to help diagnose any sleep disorders. Now, a multiple sleep latency test is an assessment of daytime sleepiness. So this person undergoes this test. So usually this is a two-part. They end up staying for 24 hours. So most of the time they do the nighttime one and then they stay during the day. And so this is going to assess for daytime sleepiness. So this person undergoing the test is asked to take a daytime nap at 2-hour intervals while being attached to the same sensors that they were for the nighttime study. So the client is asked to nap for about 20 minutes, and these naps are repeated 4 to 5 times throughout the day. So every 2 hours, they take a 20-minute nap. The clients who have certain sleep disorders causing daytime sleepiness have a short latency period, and that is they'll fall asleep in less than 5 minutes. So most well-rested persons take an average of 15 minutes before they experience the onset of daytime sleep. Experiencing early REM sleep is also a pathologic finding that can be detected during the multiple sleep latency test. A REM period normally does not occur for at least 1 hour and after cycling through the stages of NREM. Therefore, REM should not occur during a 20-minute test nap. So if you don't have some type of sleep disorder, and is especially looking towards like narcolepsy and things like that, you should not fall asleep and hit REM in one of these 20-minute sleep naps. So if you do this, and I think with narcolepsy, I believe you should hit it in like, if you hit it in 3 of the 5 naps, then it is going to definitely be deemed abnormal. So now the patients had the thorough assessment and now they've had their sleep study. Now we'll talk about the patient who's actually been diagnosed with a sleep disorder. So about 40 million Americans have some type of sleep disorder, the most common being insomnia, followed by sleep apnea. And insomnia means difficulty in falling asleep, awakening frequently during the night, or awakening early. It results in feeling unrested the next day. Hypersomnia is a sleep disorder characterized by feeling sleepy despite getting normal sleep. Two conditions of hypersomnia are sleep apnea and narcolepsy. Sleep apnea is where the sleeper stops breathing or breathing slows for 10 seconds or longer and 5 or more times per hour. During these apneic episodes, ventilation decreases and blood oxygenation drops. The accumulation of carbon dioxide and the fall in oxygen causes brief periods of awakening throughout the night. This disturbs the normal transition in periods of NREM and REM sleep. Consequently, clients with sleep apnea feel tired after having slept, or worse, their symptoms may cause a heart attack, stroke, or sudden death from hypoxia of the heart, brain, and other organs. The incidence of sleep apnea is highest among older adults, especially obese men who snore. Methods to reduce apneic events include sleeping in positions other than the supine position, losing weight, sleeping in, avoiding substances that depress respiration such as alcohol or sleep medications, and in severe cases, the client may need to wear a continuous positive airway pressure or CPAP mask that keeps the alveoli inflated during sleep. Surgery on the tonsils, uvula, pharynx, tongue, or epiglottis is another treatment option when conservative measures are ineffective. Narcolepsy is characterized by the sudden onset of daytime sleep, or short NREM period before the first REM phase, and pathologic manifestations of REM sleep. This disabling condition should not be confused with hypersomnolence, which is excessive sleeping for long periods. Although the diagnosis of narcolepsy generally requires a multiple sleep latency test and polysomnography, its symptoms help distinguish it from other conditions that cause sleepiness. For example, the sleepiness of narcolepsy is accompanied by the following: sleep paralysis. The person cannot move for a few minutes just before falling asleep or awakening. Cataplexy, a sudden loss of muscle tone triggered by an emotional change such as laughing or anger. Hypnagogic hallucinations, a dreamlike auditory or visual experience while dozing or falling asleep. Automatic behavior, the performance of routine tasks without full awareness or later memory of having done them. If the narcolepsy patient can take, they often prescribe stimulant drugs such as Ritalin or Adderall to help improve alertness. Antidepressants reduce the symptoms associated with atypical REM sleep. Question 3. Is the following statement true or false? Apneic episodes can be reduced by sleeping in other than the supine position, losing weight and avoiding substances that depress respirations, such as alcohol or sleeping medications. The answer is true. Apneic episodes can be reduced by sleeping in other than supine position, losing weight, and avoiding substances that depress respirations, such as alcohol or sleeping medication. A sleep-wake cycle disturbance results from a sleep schedule that involves daytime sleeping and interferes with biologic rhythms. Sleep-wake cycle disorders occur among shift workers, jet travelers, and those diagnosed with seasonal affective disorder, a cyclical mood disorder believed to be linked to diminished exposure to sunlight. So let's talk about shift workers. Those who work evening or night shifts or who switch from one shift to another are especially prone to unsynchronized sleep-wake cycles. The indoor lighting to which most shift workers are exposed to is not bright enough to suppress melatonin. Consequently, many shift workers fight to stay awake. Some experience microsleep, which is unintentional sleep lasting 20 to 30 seconds. Statistics show that shift workers are more prone to errors and accidents from sleeplessness. Most people who work night shifts never completely adapt to the reversal of day and night activities, no matter how long the pattern is established. Jet travel causes a sudden change in the currently established photoperiod to which a person is accustomed. Consequently, travelers who often describe having jet lag or emotional and physical changes experienced when arriving in a different time zone. Many travelers have difficulty falling or staying asleep, but jet lag is more transient than shift work. Some travelers reestablish normal sleep-wake cycles, but it takes at least one day for each time zone that is crossed when traveling east, slightly less when traveling west. Seasonal affective disorder is characterized by depression, hypersomnolence, a lack of energy when awake, increased appetite, accompanied by cravings for sweets and weight gain. The symptoms begin during darker winter months and disappear as daylight hours increase in the spring. In some ways, the disorder resembles the hibernation patterns of bears and other animals. Some suggest that seasonal affective disorder results from excessive melatonin. To counteract the symptoms, phototherapy is prescribed. Parasomnias are conditions associated with activities that cause arousal or partial arousal, usually during transitions in NREM sleep. They are not life-threatening, but they disturb others in the household, most significantly the bed partner. Some examples of parasomnias include somnambulism, sleepwalking, nocturnal enuresis, bedwetting, sleep talking, nightmares and night terrors, bruxism, grinding the teeth, restless leg syndrome, movement typically in the legs but occasionally in the arms and other body parts to relieve disturbing skin sensation. Restless leg syndrome is also known as nocturnal myoclonus, may be the most disturbing parasomnia. The symptoms keep the person awake or prevent continuous sleep. Eventually, sleep deprivation affects the person's life, damaging work productivity, and personal relationship. Medical etiologies such as iron deficiency, kidney failure, and peripheral nerve pathology can mimic the manifestations of restless leg syndrome. Once these conditions are diagnostically eliminated, the condition is confirmed with a polysomnography. Conservative treatment for parasomnias includes safety measures for sleepwalking, mouth devices for bruxism, lifestyle changes, nutritional support, and good sleep hygiene. In severe cases, drug therapy is used. After assessing client comfort and sleep patterns and the accompanying symptoms, nurses identify one or more nursing diagnoses that require intervention, like fatigue, impaired bed mobility, disturbed sleep pattern, sleep deprivation, readiness for enhanced sleep, relocation, stress syndrome, risk for injury, impaired gas exchange. These are all plans of care that would require appropriate nursing interventions. Several sleep promoting nursing measures such as maintaining sleep rituals, reducing intake of stimulating chemicals, promoting daytime exercise. These are important measures that can help return people to good sleep. Also, encouraging the patient to adhere to regular schedules, like going to bed at the same time, waking up at the same time, every day. Also, two additional beneficial methods are assisting the client with progressive relaxation exercise and providing back massage. Also help the patient to relax before they retire to bed. So some considerations when working with the elderly, it's important to remember that they prefer to have their own bed furnishings. They're more comfortable with using their own um, furnishings. They're more comfortable in their own beds. They prefer to be in their own environment. They also prefer to have the room a little bit warmer. Um, Insomnia and hypersomnia are frequent manifestations for depression. And with the elderly, they tend to suffer from depression a little bit more. Um, they are also more likely to suffer from sundown or sunrise syndrome, and they also benefit from relaxation techniques before bedtime. Continuing with some considerations for the elderly, the hypnotic medications not recommended for use longer than 2 weeks, right? So they tend not to be able to clear these medications, and so they're not recommended for use longer than 2 weeks. They don't work well. They don't tolerate them well, and so it's best not to use like sleep medications for the elderly. They also tend to have a difficulty falling asleep, and institutional schedules may interfere with the established patterns of sleep, and so modifications may be necessary to get them on a good sleep schedule. It's important to identify potential sources of sleep disorders. If the elderly patient is having trouble, we may need to look into like if they're having sleep apnea, if there's medications that are causing problems. We really need to look out because sleep is very beneficial, and if they're having problems sleeping, these are going to manifest as other problems. So we really need to reach out and kind of figure out what's going on with them. Cognitive impairments may result in sundown or sunrise syndrome. So again, with Parkinson's dementia, they may end up with having some episodes of sundown and sunrise syndromes. Chronic conditions can also interfere with sleep, as like pain, difficulty breathing. They frequent urination, so if they have a lot of pain, they may not be able to lay in bed as long. They may have problems turning. Difficulty breathing, they may have COPD, emphysema. They may not be able to lay flat. Frequent urination from medications like Lasix. That may cause them to have to get up more frequently. And so encouraging maybe some rest periods or short naps can actually restore energy. Having them earlier, like maybe around noon, 1 o'clock, shortly after lunch, this would not interfere with their nighttime sleep because it would just be short, maybe 30-minute, I guess one might call it a power nap. And so therefore that would not interfere with their nighttime sleep.